Randall Wolf here. Welcome to another episode of DeBakey CV Live. And I'm your host. And I have a special guest, which I will introduce in a minute. It's a conversation with a patient who had a Minimaze procedure 17 years ago. During this program, as usual, if you have any questions about AFib, and there are no, as they say, stupid questions, all questions are fair game. If you have a phone, go to the text and go put in 37607. That's 37607. And in the little text box, put in DeBakey, DEBAKEY. So you go text 37607, and in the little text box, put DeBakey, and you'll be in the program and be able to type your question. If you are on a computer, that's great. As you can see on the screen, go to pollev.com, POLLEV.com, and again, enter DeBakey, and you will be able to type your question in. I will see it during this hour, and I always try to get to every question. All questions are fair game. If you have atrial fibrillation, this is an opportunity for you to ask a question. So take that opportunity. Every month, the first Tuesday, 5 to 6 Central Time, we discuss the topic of atrial fibrillation and the minimally invasive surgical treatment of atrial fibrillation, along with some other subjects. This month is similar, but I'm very pleased to have with us Mr. Godfrey Klaber. Mr. Klaber is an electrical engineer by trade. He is now retired. And what reminded me of him is that he sent me a letter recently explaining where he was in his AFib journey. And I thought it would be very helpful to you out there that have AFib to listen to his story. It's a little bit of a testimonial, I guess, but you may be able to relate with what he went through with atrial fibrillation. Mr. Klaber's also been very kind, and he said he would share his email with you. So if you would like to talk with him after the show, you can send an email to orange6527. That's the color orange, orange6527 at yahoo.com. A little teaser for the next show. There is an illusion, a magic illusion that is based on the Minimaze procedure. And recently, a video was completed by my son that gives a little insight into how this happened. It is arguably the only surgical procedure that is turned into a stage illusion in Vegas. And I hope to share that with you, not this today, but a week from today on Tuesday. So again, you can send us questions anytime during the show. They will come up on the screen. I'll be able to see them. You will not be able to see them. I'll be able to see them. And the question can be for me, or it can be for Mr. Klaber, or it can be for both of us. That's fine. So let's start out. I'd like to introduce Mr. Klaber to you now. He's been kind enough to join us from his home in Westchester, which is a northern suburb of Cincinnati. Mr. Klaber, again, thank you for taking the time out and getting your computer to work properly to join us on this show. And you have the floor.
All right. So I'd like to read some letters that I've written about you. I had the Wolf Minimaze in January of 2004. This is a letter I wrote to Carl Lindner. I would like to thank you for your efforts in bringing Dr. Randall K. Wolf back to Cincinnati and your generous gift of $1.5 million for the second Da Vinci robot at the University Hospital. At this time, I was 75 years old. In December of 2003, I had 15 occurrences of atrial fibrillation that lasted from 1 to 6 hours and required that I take quinidine sulfate, a medicine that has many disagreeable side effects and resulted in many hours of me lying down. On January 13, 2004, Dr. Wolf used the Da Vinci robot to perform a Wolf Minimaze procedure to eliminate my atrial fibrillation that I had had since 1970. The procedure ended the bouts of atrial fibrillation that had made my life so miserable for me. It is so nice not to have atrial fib anymore. Thank you so much for your generosity. Then another letter that I sent to Dr. Wolf on June 30th, 2005. Dear Dr. Wolf, as I was walking from my garden the other day, I reflected on how much I am enjoying life since I had the Wolf Minimaze operation. I said to myself, I must write Dr. Wolf and tell him how much I appreciate the change he has made in my life. To fully understand the magnitude of these changes, I would like to delineate how things were for me before the operation. As I indicated when I visited you on January 6, 2004, I had 15 events of atrial fibrillation in December 2003. Beginning some 34 years ago, these events usually lasted 2 to 6 hours, and with quinidine sulfate as the method of restoring the normal rhythm. The resulting pattern was that of lying down for most of that time. My life was like walking a tightrope. Everything I did was reviewed as to how it might cause atrial fib. I could feel sorry for Pavlov's sheep that he didn't know when the experimental shock was coming. I too never knew when atrial fib would occur. I had to be very careful of what I ate. My diet was extremely limited. Many things seemed to trigger the beginning of atrial fib. Planning any event or trip was always threatened with a cancellation or a 6-hour delay. When I was still working, I had to call in sick many times and then go into work later when I really didn't feel like it. Not only did this affect my life, but also my family's, especially my wife, who on many occasions had to cancel a trip or some event. As time goes on after the operation, I was able to eat more things, and today I can enjoy eating most everything. I've gained 20 pounds plus and had to buy new pants. I eat more than the American diet, and this is not the healthy thing to do. I am continuing my active lifestyle and find many interesting things to do: walking, gardening, some travel, grandchildren, and just enjoying life. At any rate, I want to thank you for how you have made such a positive improvement in my life. I am very thankful there are people like you, innovators and pioneers in your field, people who push the envelope to invent and find new ways, thinkers who put their ideas to work. I have since seen the operation on cable TV and watched it with much interest. And then my latest letter to you. I can get the paper separated here. This was written April 16th, 2021. I'm writing to you once again to thank you for getting rid of my atrial fib. Your operation relieved me of the atrial fib that was making my life miserable, and it has also imparted impacted my wife's life too. In December 2003, I had 15 episodes of atrial fib that would last 4 to 6 hours until the quinidine sulfate restored the rhythm. After 4 to 6 hours of quinidine sulfate, I did not feel like too well for several hours. Besides making my life miserable, I missed a lot of work, and it caused a lot of plans to be canceled. And in January 2004, you performed your amazing surgery on me and changed my life for the better. I am now 92 years old, and about a year ago, I developed worsening peripheral neuropathy, and it is difficult to walk. I'm doing PT for that problem. Other than some stomach problems, I'm doing okay. Due to the virus, we haven't been to the gym since 2019. And then I signed my name. And I want to thank you, Dr. Wolf, because it's people like you that make the difference in the world. I'm sure at night when you go home, you have a good feeling because you've done something great for mankind.
Well, thank you so much. My guess is there are a lot of people out there suffering from AFib that can relate to your story, who feel that they have a time bomb. They just don't know when it's going to go off in their body. We've heard that story before, and I think they'll also be very interested to hear that it's possible to have a solution to a problem that most people think there is no solution. Many physicians will tell people you have AFib, you're going to have to live with it for the rest of your life. You will be on blood thinners for the rest of your life. Suck it up and live with it.
I heard that a lot.
You were a little bit of a pioneer yourself. I don't know if you know that, but I started the procedure in 2003 at the University of Cincinnati.
Yes, in the fall. Of that year. In the fall of that year.
Yeah, so you were probably number 3 or 4 for the procedure. We're now over 2,000 patients. And I want to let our audience also know a little tidbit. I mentioned it briefly on your introduction that you were by training an electrical engineer. My dad graduated from University of Cincinnati as a chemical engineer. And at the time we did your procedure, I was teaching engineering at University of Cincinnati. And the procedure that came together had to start with a device. And the device was put together by Mike Hooven, who's an electrical engineer, and myself in the lab, in the animal lab. We spent a good part of 2 years in the animal lab perfecting the device, because there is no procedure without the device. So the device was developed in Cincinnati by an electrical engineer. I helped him with the design and how to use it and what to put on it. And so it's a engineering story, and that's really where the innovation started. The second part of the innovation was figuring out that we could use this device without doing open heart surgery. Originally, all the procedures with this new device to treat AFib were for open heart. But what was different in 2003 in the fall was I started using it for a minimally invasive procedure in people like you who didn't need open heart surgery. And that was a big breakthrough. And again, that was based on a year and a half in the lab, both in animal and cadaver lab. So there was a tremendous amount of research that went into it. And I think we got it right the first time, which is unusual, but that clamp is still being used today. And that clamp is the most used device for surgical AFib in the world, not just the US, but the world. The device is still made in Cincinnati, and it's shipped all around the United States, all over Europe and Asia. So it's a real success story for the company that after we made the device became known as AtriCure, which is also in Cincinnati. If anybody has any questions, go on your phone, go 37607, and then a text box, put DeBakey, DEBAKEY. Or if you're on your computer, go to pollev.com/DeBakey. You'll also find more information about what we're talking about on wolfminimaze.com, wolfminimaze.com. So at the time when you had to decide what to do about your AFib, go through with us what you were told your choices were, number one, and two, how you found out about truly a new procedure at the time.
Well, I had been to many doctors, and they offered drugs to control it. That didn't work very well. One famous hospital said the only way to deal with it is cut part of your heart out, which I didn't like too much. And in the fall of 2000, let's see, that'd be 2003, yes, we read an article in the paper about your work with minimally invasive procedure.
Mm-hmm.
And at the time, I told my wife, I think I'd risk an operation just to get rid of this terrible
Scrooge.
Yeah. So at any rate, I think we came to see you on a Tuesday in January. The next Tuesday, you were operating. And,
Yep.
And then along about 28th of February, we had a cruise plan, and then we took off for a cruise.
Well, for most people out there, if you are, between the ages of 18 and about 90, and you're diagnosed with AFib, your options are one, take medicines, which sometimes work. They generally fail over time. And first of all, I'll ask you a quick question, Godfrey. Initially, did the quinidine work?
Well, at one time, a long time ago, when I was working at WCPO, I worked a graveyard shift, and I came up with irregular heartbeat, and local doctor gave me some quinidine sulfate. I think I took one or two of those, and it regulated. So, and then I wasn't bugged with that for quite a while.
So generally may work, but they tend to fail after a while.
Yes, well, I was quite young then. Quite young then.
About 40% of the time they'll work, but generally they all fail over time. The next option that is usually recommended to patients is a catheter ablation. The catheter ablation is done with entrance through the groin, and then catheters in the right side of the heart, which then a hole is made from the right side to the left side of the heart. And then the catheters either burn or freeze the heart tissue from the inside. And their premise is that the AFib comes from around the pulmonary vein orifices. And if they freeze or burn around the pulmonary veins, that should stop the AFib. Unfortunately, that doesn't work a lot of times. Many people have 2, 3, 4 ablations. I've seen people with as many as 6 failed ablations. The most common complication of a failed catheter ablation is atrial flutter. And many patients say the atrial flutter is worse than the atrial fibrillation that they had. They wish they had their old AFib back. Also, the catheter ablation usually doesn't address the left atrial appendage, the little ear on the heart, the cul-de-sac, the dead end, where blood can stagnate and coagulate. It doesn't matter what type of mammal you are. If you're warm-blooded and your blood slows down, it clots. And that can happen in the little appendix of the heart. If it does, that can break loose, leave the heart, and go to the brain and become a stroke. So
you clipped mine off.
Yeah. And it's not unusual for me to see a patient who found out they had AFib when they presented with a stroke. So sometimes the presenting symptom of AFib is a stroke, unfortunately, for some people. But anyway, during a catheter ablation, that's usually not addressed. And also that little appendix, that appendage, in some patients is the source of the AFib. So there's another reason to treat the appendage. Yeah, go ahead.
Prior to all this happening, I had a cardiologist, Dr. Art Simon, and he acquainted me with the experiments that were being done in Europe, where they found that up on the pulmonary veins, there were signals being generated that came down and interfered with the pacemaker. And they were looking at doing an ablation on the inside of the pulmonary veins, but that was resulting in stenosis or blockage of the veins. So I didn't go for that.
Yeah, that early on, that was a problem. You're referring to the work by Vascular in Europe. He published his paper in 1998. And that was the genesis of us trying to decide how we could treat that much more quickly with a device. The clamp that was developed by Mike Hooven and myself and all the engineers at a small company called Enable Medical that then spun off Atrial later was to create something that could be used quickly and easily. Catheter ablations were taking up to 13 hours to perform. The clamp that we developed creates a complete line around the pulmonary veins in about 12 seconds. And not only is it quick, it's complete. And what we found with the catheter ablation, it's very hard to get a line all the way through the heart from the inside to the outside. But with the clamp, it's very easy because when the clamp is closed, there's no blood there. So it's very easy to make a line all the way through. The Minimaze, as opposed to the catheter ablation, uses incisions under the armpit on each side under general anesthetic. So you could say that it's more invasive compared to the catheter ablation on the skin. But on the heart, the Minimaze is less invasive because we can simply make a line to completely isolate the pulmonary veins. But what I found out after doing this a little bit was that the veins weren't really the problem. It was a false premise to say if we burn the veins or freeze the veins, we'll stop AFib. The real culprit are little nerves on the outside of the heart. These are autonomic nerves. These are the nerves that make your hands sweat when you look over the edge of a tall building. Why should your hands begin to sweat? These are your autonomic nerves. They're the nerves that make your heart rate speed up when you are watching a scary movie. Why should your heart rate speed up? You're sitting in a chair. These are the autonomic nerves, and these autonomic nerve branches from the vagus nerve are extremely rich around the heart in one particular place, around the pulmonary veins. But the nerves are on the outside of the heart, not the inside. And what we quickly realized that with the clamp, not only were we creating a complete line through the heart, we were isolating these little nerves on the outside that you cannot get to with a catheter ablation. So I wrote a paper a few years after that about how to test these little nerves, ablate these little nerves, and then test again to make sure the nerves are completely ablated. And that is the genesis of AFib, I believe, in most patients that have lone AFib or vago AFib. We added from the very beginning closing the appendage, initially to prevent blood clots that might form in that area. But then I also found out that not only does closing the appendage, cutting it off, decrease the chance of a stroke dramatically, it also electrically isolates the appendage. And in some patients, that's the source of their AFib. So closing the appendage became important for two reasons. And I incorporated that from the very beginning of the procedure. So the procedure hasn't really changed that much in 17 years. There have been a little tweaks here and there, but it really hasn't changed very much. So the procedure that you had included pulmonary vein isolation, which in retrospect also isolated the little nerves on the outside of the heart, and closure of the left atrial appendage. Yeah. Now, at the time, we called it bilateral pulmonary vein isolation and closure of an excision of the left atrial appendage. There was a patient at the VA in Cincinnati who was a skydiver, and he came to me a year after the procedure, and he said, "Doc, I got a present for you." And I said, "What is it, George?" He said, "You need a website." And I said, "Well, let's talk about it." He said, "It's Christmas time, and my present to you is a website." And I said, "George, I'd just be happy that you're in sinus rhythm," which he was. And he got back to skydiving. He was a skydiving photographer, so he took pictures of other skydivers when they all jumped out of a plane. He said, "You need a website." And I said, "Let's talk about it." He said, "No, you don't understand. I've already done it." And he turned on his computer and he showed it to me, and it said Wolf Minimaze. So Wolf Minimaze was the brainchild of one of the patients early on in the first couple years by the name of George Rabe. That's where that came from. And he was a patient at the VA in Cincinnati. He was told he just had to take medicine. He left the VA, came over to see me at University Hospital, and had what's now known as the Wolf Minimaze. What advice might you have for someone who's early on in the game, like you were 18 years ago now, and you're given the choice of more medications or a catheter ablation?
Oh, I would take the Wolf Minimaze.
The proof's in the pudding, right?
Yes.
Now, what medications are you? Let me rephrase that. Are you taking any heart medications presently?
Yeah, I'm taking digoxin 0.125. That's practically nothing. And early in my early manhood, some doctor determined that he was going to get rid of my dandruff with x-rays, and unfortunately it had some impact on my thyroid, so I take some thyroid medicine, levothyroxine.
Well, it must have done some good. You still got a pretty good head of hair at 92. Or you could say, think how much thicker it would be if I wouldn't have had that done.
Yeah.
So you're not taking a blood thinner, correct?
Oh no, I was encouraged to do that, and I resisted that.
Yeah. And the blood thinners are, of course, they're newer ones now. Back 17 years ago, it was mainly Coumadin. Yes. Now there are newer blood thinners, but they still have side effects. They're very expensive, and they can also lead to a different type of stroke called a hemorrhagic stroke. That's when there's bleeding because the blood is too thin or someone hits their head. I had a fellow come see me about a year and a half ago, and he came in, sat down. He didn't take off his baseball cap. And I looked in his chart, and he had seen me 3 years prior for AFib. And I gave him the options, and he opted to take the blood thinners. And I said, "Why are you back?" And he took off his ball cap, and he had a big incision where he'd had a craniotomy. And he said, "I was on a ladder painting, fell off, hit my head. And because I was on blood thinners, I bled into my head and had a stroke and had emergency surgery to stop the bleeding." And he said, "I'm recovered for that, and I don't want to be on blood thinners anymore. And I'd really like to have the Wolf Minimaze," which fortunately we were able to do. So some of the complications of AFib are from little pieces of clot breaking off going to the brain, but unfortunately some are from being on the blood thinner as well. And you may have thought of that.
Yes.
Another topic that comes up is closing the left atrial appendage with the clip or a stapler, as I did it in your case. For the first 10 years of the Minimaze, I mainly used a stapler, which closed the appendage and removed it at one fell swoop. And that stapler was also made in Cincinnati, by the way, at Ethicon Endosurgery. After that, AtriCure in Cincinnati then developed a clip which closes the appendage without having to cut it off. And generally, we use the clip now, which is equally as effective as the stapler. It's perceived that some of the competition to that is a device called the Watchman device. The Watchman device is like a cork that you stick in a bottle. So if this is the appendage, the Watchman device goes up into the appendage, opens up, and theoretically stops flow in the appendage. Unfortunately, oftentimes it does not stop the flow and leaks. And in fact, the risk of stroke is higher right after the Watchman than before. And more importantly, or as importantly, the Watchman device, because it's a cork, does not electrically isolate the appendage. So the appendage is still active and available, unfortunately, for AFib. So I'm not a big fan of the Watchman. For the first time in my practice, a couple of weeks ago, I operated on a patient who already had a Watchman. And that's a pretty tricky operation with that cork already in the appendage. We couldn't close it off. I burned around the base of the Watchman to try to render the appendage electrically isolated, but that's about all we could do on the left side. There's another procedure that's come up, Godfrey, since your time dealing with this. That's called the convergent procedure, and that's gaining some popularity. In the convergent procedure, the surgeon goes in below or above the belly button and below the chest bone and burns as much as they can on the back of the heart. Then a catheter ablation is done sometime later to complete the procedure. And sometimes the surgeon will go in from the left side and close the appendage. And I've seen some patients who's had that procedure who still have AFib. Unfortunately, after that procedure, I cannot go in on the left side because the clip is there. They've already had surgery on the left side. So I'm relegated to only going in on the right side to treat the nerves called the ganglionic plexi and completely isolate the veins. What I generally see in patients who've had catheter ablation that come for the Minimaze, and these are things I didn't know when we were doing your procedure because we hadn't seen anybody that had a catheter ablation before the Minimaze at that time. But what I see now, about half the patients have had previous catheter ablations, 1 up to 6, is that the veins are not completely isolated. They're still active on the outside, and the nerves are still active as well. And we find that once we do what we do, which is completely isolate the veins and take care of the nerves and close the appendage, then the AFib goes away. So we have learned a lot, and things have evolved as far as the type of patients that we see. If you have any questions, if anybody has any questions, you can go to your phone and on 37607, then in the text box, put DeBakey, or you can go to pollev.com/DeBakey. Did any, Mr. Klaber, did the fact that you were an electrical engineer have any part to play in your willingness to go with a fairly new procedure?
Not much. I was so aggravated with what atrial fib done to me that I would do almost anything.
Did I share with you that I had worked with an electrical engineer to produce the device?
I don't recall if you did or not, but I was impressed.
There are people that come to see us that are in dangerous professions. I took care of somebody from Washington last month who has a rather dangerous profession. Policemen, we see policemen, a private detective from Atlanta last month. These people cannot afford to be on a blood thinner, as you can imagine.
Yes.
Also, pilots. We found that if pilots have AFib, they get grounded. And for commercial pilots, that's their livelihood. And if they have a catheter ablation, they're still on medications. They're still on blood thinners. But if they have the Minimaze, they're off medications and they get a full physical clearance, which means for commercial, they get a physical every 6 months. So we're able to get these guys and gals back up in the air quickly. And some people have come to call the Minimaze the one and done solution, as opposed to having multiple procedures with something on the inside of the heart. The other thing I'd like to mention, this is something we didn't know at all when we did your procedure, but at DeBakey Heart and Vascular, there is a technique to watch the blood flow in the brain, and it's called transcranial Doppler. And by putting a probe on the outside of the head, we can watch the blood that's going into the brain. And if there's any particulate matter, a little piece of clot or a scab or some air, this device will pick it up. It doesn't miss anything. And it measures what are called hits. So if it sees a little something going up into the brain, that's one hit. Okay? And with catheter ablation, the device was placed on the outside of the head during the ablation, and the number of hits, little particulate matter that was going to the brain, was measured. And the average number of hits was 2,000 to 4,000 per procedure. Now, this technique was repeated also in Europe, and exactly the same findings. 2,000 to 4,000 little pieces of stuff were going through the middle cerebral artery into the brain. Some people have commented after a catheter ablation, they sort of get foggy for a little while, or they have a terrible headache for a few days. And they were attributing this to the fact that with the catheter, they went through the wall of the heart from the right to the left side. But I suspect that the reason they got these symptoms was all this little pieces of stuff that was going into the brain. Not enough usually to cause an overt stroke, but certainly enough to mess things up a little bit. So we thought, well, let's try it with the Minimaze now that I'm at Methodist and DeBakey. So on about 10 patients, we measured continuously the flow into the brain through the middle cerebral artery during a Minimaze. After 10 patients, we stopped because the researchers said we don't see any. So instead of 2,000 to 4,000, they saw 0 to 2. And they said it's insignificant and we're going to stop watching your patients. That one of these articles was published in Europe a few years ago. We turned in an abstract to one of the big meetings. We'll see if it's accepted because that's something that most people don't know anything about, who undergo catheter ablation or who undergo minimally invasive surgery for AFib. And I bet you didn't know about that.
No, I didn't.
But it's pretty fascinating. If someone would like to reach you, you were kind enough to give your email, orange6527@yahoo.com. orange6527@yahoo.com. We also, for the audience out there, if you want more information on what we do at Houston Methodist with minimally invasive surgical AFib, that's wolfminimaze.com. Or if you prefer to use the phone, it's 713-441-9342. 713-441-9342. Mr. Klaber, what would be your suggestions to anybody who is going through this journey 17 years back when you went through it, but going through it now, but as you look back before you made a decision. I tell people they should do their homework because you need to become informed. And I think that's what you did, because probably your physicians didn't tell you there was a new procedure being done at University Hospital at the time. So I think an informed patient is probably the first step.
I agree.
And because you went out and sort of did your own homework is how you found out about this. I also recommend to patients, please go ahead and see someone about a catheter ablation, about drugs, but also see someone about the Minimaze so you can make an informed decision based on all the options. Sometimes I think patients don't have all the options, and I think that, or I know that's a shame.
Well, you have to see the right people, because I saw so many doctors that didn't give me any hope.
You hit on a very important point, and one that I like to emphasize. This is lost on a lot of physicians, unfortunately. Patients want hope, and hope is halfway to happiness. I do magic, and the same thing is true in magic. People are hoping for something, and they hope for a little magic, and they get it, and they're happy. But hope is very important, and the death sentence, so to speak, of you'll have to be on blood thinners for the rest of your life, and you'll just have to live with AFib, period, is not a good message, especially since, in fact, there are options. So I think that point that you just made is a very important one.
Yes.
So for those of you out there listening to this presentation, this is DeBakey CV Live. This is the episode from May 2021. I want to thank Alan Lumsden. Alan Lumsden is the director of DeBakey Heart and Vascular Center, and he's the one that had the brainchild to think of all this and put it all together so that you can be in a different place from me, and neither one of us has to be in Houston, and we can have a webcast and inform people to do what we were just talking about. Allow patients to become better informed healthcare consumers, I guess is the word we use today. You're no longer a patient, you're a healthcare consumer. But being a healthcare consumer is not very good if you're not well informed.
Well, I can never thank you enough for what you did for me. It's tremendous, and I owe you a tremendous debt.
Well, I think you paid it back. You wrote some very nice letters, and you also agreed to be with me on this webcast. And I'm sure some people have heard your story, and it will probably influence them and help them. So through this mechanism, you have helped other people.
Yeah,
and I want to thank you. I want to thank you for joining us. Again, I believe we're on again in a month, first Tuesday, 5 p.m. Central Time. I think July will be, there won't be a show because that's the middle of summer. Until then, this is Dr. Randall Wolf, arrhythmia specialist at DeBakey Heart and Vascular Center, speaking with Mr. Klaber from Cincinnati, who had a Minimaze 17 years ago. Thank you all for watching this segment of DeBakey CV Live.